Hello, everybody, and welcome to Ask Concussion Doc. Today, I am joined by a very special guest. Jenni Diamond is an OT, which is an occupational therapist, for those that don't know, and she's also a certified personal trainer. She is the director of occupational therapy at the Neurology Centre of Toronto, and she manages a team of therapists and provides treatment to patients who have sustained concussions. Jenni is passionate about concussion prevention, education, and management. And if you want to see her, you can go and check out her website, jennidiamondhealth.com, and that's Jenni with an I, Jenni, diamondhealth.com. You can also check her out on social media, Jenni Diamond Health, and at the.concussion.ots on Instagram. And you can also check out her clinic, which is the Neurology Centre Toronto. Welcome.
Thank you so much for having me.
I think the first time we chatted, you were actually listening to this podcast. So full circle.
That is exactly it. Yeah, I sent you a message and I think I had some follow-up questions, and from there we just got chatting. So
right.
Nice to pull things back in here.
Yeah, for sure. We did a thing on the Concussion Fix program as well, where you came in and gave us a talk on return to work. And that is exactly what we are talking about today, because I think it's such an important topic and one that a lot of people struggle with in trying to get back to work, back to life, back to everything post-concussion. And so obviously work makes up a lot of what we do. And so it's an important thing to be able to get back into. Where are my notes here? Okay. All right. Did you run into any issues with your college yet?
Oh, from your post? Yeah. So I guess for everyone, no issues. But for everyone listening, OTs are not allowed to say they specialize in anything because our training is general. We can work with a variety of populations. So I would not say that I specialize in concussion, but I would say that I work with patients who've sustained concussions. And so Dr. Marshall posted something saying that I specialized, and I had to correct him on that terminology.
Yeah. Sorry about that. I hope I didn't get you in trouble.
That's okay. Yeah. You're all good.
Yeah. So we were just chatting before we came online. You went to Western and you did kinesiology.
Yeah, I did my bachelor's of science in kinesiology at Western, and then I went on to pursue my master's in occupational therapy at the University of Toronto.
Why OT? What got you into OT in the start? We'll ask some background questions here to set it up.
Yeah, so I knew I wanted something in rehabilitation medicine. I'm like working hands-on. I like making a difference in people's lives. I was always interested in health, wellness, neurology. So all of those things drove me, and I was really actually considering mostly between physiotherapy and occupational therapy. And what drew me to occupational therapy specifically was really the holistic lens you can provide in healthcare. And it's not just about physical changes, but there's a huge focus on the cognitive aspects, which we'll touch on today, because those are very significant in trying to get back to work. And there's a big mental health focus as well. So I like that there wasn't as much of a ceiling with your typical role and scope of practice, and that you can approach it from many different angles.
So this is also a question that a lot of patients will have is, what is OT?
It's a great question. And yeah, I'll give you a definition and I'll give you some examples. But really what occupational therapy comes down to is working with patients to help them improve their performance or participation in their daily activities. So whether that's work, school, things people like to do for fun, anything that's an important part of their daily life. And so what that actually translates to in various work settings is it might be helping school-age children with foundational school-based skills, maybe for little kids like scissor skills or handwriting or things like that. Or it might be working with someone who has had a spinal cord injury to strengthen again and improve their function through their hands and teach ways to modify their movements and daily activities so they can feed and dress themselves. And so when it comes down to concussion, what my role is at the Neurology Center is to work with patients to help them get back to work or get back to school or doing all the things that are now so much more challenging because of their symptoms. And then we also do a lot of symptom management and, of course, provide this concussion education, which can be so empowering for people in their recovery once you know what is actually happening during your recovery and how should you be approaching your recovery.
Yeah, it's one of those things where it's called occupational therapy, but it doesn't necessarily have to be vocational, right? It can be school,
Well,
life,
it's
function.
yeah, it's a little misleading, the name, but if you actually look up the term occupation, really it's anything that's an important role in your life.
Mm.
So if you're a father, right? Like you have kids, your one of your occupations is being a father. So it's not just your job, although we tend to use the term occupation more to think of what you do for a living. But it really can be any important role you have in your life.
Wow, I did not know that was the definition of occupation. So it seems
I
like
think this
then,
is why no one knows what OTs do.
right? Yeah, it's true. I think it's true. Um,
Yeah,
so it's actually the English language then that's messed up the definition, but OT has it right.
absolutely. Exactly.
And then your on the concussion side, what drew you into that realm of things?
It's a good question. It's not that I always knew I wanted to work in concussion. I mean, I fortunately have not had to recover from any concussions myself in the past. I have always loved neurology and the brain, and I knew I wanted to do something psychomotor related or just something related to either a brain injury or some kind of related realm of practice. I actually, for a while, thought I was going to work in spinal cord injury, and then was introduced to more concussion scenarios and placement examples, and that really drew me in. But I think so. So I'm not sure what initially captured me, but what continues to draw me in is how it's a few things. One is that concussion is it's a very I need to be careful with my wording here because it is not an uplifting injury for the patient. It is incredibly debilitating and serious and challenging, as you know. But as a healthcare provider, it's incredibly rewarding because you see your patients get better and you really see those changes. And I think day to day for the patients themselves, they don't always see them for quite some time longer than you do, but they come back and all of a sudden, they can do 30 more minutes of reading and you're like, oh my gosh, that's incredible. And so it really is so rewarding. And because, OT, as we discussed, it's so focused around occupations and daily activities. It's such a well positioned healthcare profession for concussion rehab because so much of concussion rehab is focused on how to get back to your activities and doing so in a slow and gradual way and through adaptations or through progressive challenges. And so it's just so perfectly situated for OT. So that's really what continues to draw me to this area of practice.
I would have to agree with you there. I think it's the debilitating side of things for the patients that come in, especially because there is, and it's getting better obviously, but there's just so few clinicians that, are able to um, understand concussion to a high enough degree to be able to impact their patients in a way that allows them to get better. And so when they come to you, a lot of times it's like it's just they've been completely misled, completely misinformed, and you can make small changes and get them on the right path, and then it's like mind blowing for the patient, right? Like, and that's the thing that I just love about it, is being able to take somebody who's going through something so difficult and put them on the right path and see tremendous improvements,
Yeah.
in a relatively short period of time. So I think that's,
It's life changing,
yeah,
really.
it is.
It totally is. So,
Yeah, it's awesome. So I think we're both on the same page there. Um, okay, so let's talk about your clinic,
mhm.
the Neurology Center. How long have you been there?
I've been at the Neurology Centre of Toronto for going on almost 4 years now.
Okay, has it been around that long, or how long has it been around?
So it's been around for, I believe, 6 years.
Okay.
So I got there about in the second year that it had been around. And at the time I joined, there was one psychotherapist and then a whole neurology team. And then now we actually have two going on three psychotherapists, two physiotherapists, and now five occupational therapists, which is pretty
Wow.
cool.
Wow. And is it all concussion, or is it a variety of neurological
It's
injuries?
it's actually a variety of neurological issues. We focus primarily on concussion, chronic headache, epilepsy, and various conditions managed with medical cannabis treatment. So those are, I'd say, the four main key areas, but we see any neurological issue.
Cool.
And it's OHIP covered in Ontario for people listening. The medical appointments are OHIP covered. The allied health, so the physio, the psychotherapy, and the OT appointments, those would be separate out of pocket, but your basic medical appointments are OHIP covered.
And a lot of people would have coverage through, employer benefits and also motor vehicle accident insurance and stuff like that. So
exactly.
a lot of times people don't realize how much coverage they actually have for certain things. So look into it.
Actually, so for anyone listening, if you're listening to this podcast or live or after the fact, you're probably listening because you're working on a return to work plan. If you are on short or long-term disability and you have a case manager and have insurance through your workplace, make sure you ask them if there's coverage for OT, because even if it doesn't come in your normal benefit plan, they almost always have a budget that they can allocate, and they tend to support occupational therapy especially if the goal of it is to help you get back to work. So if you're ready to go back to work, they will often fund OT sessions. So that is like a really big trick that I learned in my first year of practice, and now I just tell all my patients, and it's really amazing.
Yeah, I mean, it makes sense too, because most of the expense that insurance companies have is paying for long-term disability. So
exactly.
they are highly motivated to get
people back,
get you off disability and back to work, and so it makes sense that they would be willing to put that up. So I think that's good advice to ask for that, because I think it's important. So let's talk about the subject we are here to talk about, which is returning to work. Now, I'm just going to throw a couple stats out there just to show people, how big of an issue this actually is. So 30 to 40% of patients with concussion will end up with persistent concussion symptoms. Okay, so that's kind of the range. 30 to 40% of patients with concussions will end up with persistent symptoms. The definition of that kind of fluctuates, but generally let's consider that to be around a month. 60% of those patients with PCS are still not back to work within 6 months of the injury. So there's now getting into your, short and long-term disability claims. So that basically works out to between 18 to 24% of everyone who gets a concussion will be off work or out of work for 6 months. Now, I think this is preventable if we were to do the right things, and I'm sure, Jenni, you completely agree with me. But I just wanted to frame it in that way to just showcase kind of what that is. Almost a quarter of patients who get a concussion who are adults and working will not be back to work within 6 months of the injury. So yeah, that's insane, and I think it's a travesty, because it's, I think, completely preventable if we were to do things the right way up front. But I just think people are mismanaged off the bat. But so let's start first. I want to kind of frame it as, let's talk first about PCS, persistent symptoms, because these are the people that you're already behind the 8 ball. It's a little bit more of an uphill battle to try and do now that you're in this situation. And then I think at the end we'll talk about acute and how we can maybe prevent this and maybe do things up front. If you've just had a concussion, or if you know someone who's just had it, you can send them this to say, here's what you should do up front so that you don't end up on disability and off work for an extended period of time. So let's start first with PCS. So how do you go about helping somebody who's been off for 6 months, a year, 2 years, 3 years, start that process? I'm assuming it has to do with what type of job they have.
Yes, so it has to do with what type of job they have. And so, there's a bunch of different assessments we'll do. A lot of it just even narrative interview style, just to get the information from them. So of course we want to find out, what type of job do they do? What kind of hours do they work? What's the commute like? All of these important details so that we know what we're trying to get them back to doing. And then what we need to know is, well, what is their current capacity like for their daily activities? Because it's going to make a huge difference getting someone back to work who can already do, 4 or 5 hours a day of computer time, but just, can't work their actual job, versus someone who can barely even tolerate looking at a screen for 5 minutes. So we need to know our starting point and our end point is basically the first step there.
And so you've established your starting point, your end point. What are the demands of the job? Where are you at now? And maybe we can think about a few kind of case examples of somebody who's, let's say, an office worker, somebody who's, let's say, a construction worker, somebody who does a little bit more manual work. How do you go about progressing that, along a path? I know it's gonna be different for every patient, but just maybe a
Mhm.
general.
Yeah. So the protocol that I typically follow is I look at, okay, so what is the minimum number of hours we want you to be able to do and send you back to work and be able to do? And for most people, that's somewhere around a 2 to 3 hour workday, either 2 or 3 days a week. And that has wiggle room depending on the individual, on their insurance, on their employer, etc. So depending on what they can do, my goal usually is to prepare someone so that they can go back and successfully do a 2 or 3 hour workday 3 days a week. That's usually where I start them from. And what I'm trying to do with that goal, that initial goal in mind, is I'm looking at, okay, what types of activities do they need to do in that 3 hour workday? So let's take the example of someone with an office job who spends their entire day on the computer, maybe, spends a lot of time making presentations, reviewing notes on Microsoft Excel, and has lots of Zoom meetings, for example. And so we're looking at, okay, before we can even consider a return to work plan, we need to make sure you can do 3 hours of those types of work like activities. And so we're going to get them practicing reviewing documents on Excel. We're going to get them practice creating presentations. We're going to get them practice FaceTiming or Zooming and engaging with video calls. And so we basically see, can they get up to that 3 hours, and that's with various accommodations, things like, and we can get into what types of accommodations might someone have. But just for one example, a really common accommodation I give people to start off with is taking a 5 to 10 minute rest break every 30 minutes throughout their workday. So if they've done 30 minutes on the screen, they get up, they take 5 minutes, take some time away from the screen, do some breathing, do a meditation, come back, okay, next half hour block. So once they can do that 3 hours, we know it's realistic. We can probably get them back to work if they can do 3 hours of work like activities. Now, for someone who is in construction, that might involve heavy lifting. That might require more exercise stamina. We need to look at, are they exercising, which should already be part of their rehab plan anyways, because we know that is one of the key pieces to getting better. And, how high is their heart rate going to go? Is that going to trigger symptoms? So all these other factors, really you're looking at what are the demands of the job and can you mimic those as close as we can. I have a lot of teachers actually, I guess, because right now it's early November, and September, October, I've had tons of teachers, I guess, with school coming back. And we've done a lot of work around seeing, in some cases, teachers are volunteering or shadowing in classrooms to get exposure to the busyness of the classroom, the lights, the noise. And if they can't go to the classroom, they can do that in a coffee shop, or they can do it on a busy street, or trying to mimic those work-like activities. So I guess I'll just add one more note here to wrap up this answer, and then I'll pass it back over to you. But what I like to do is say, okay, if you can do a 3 hour mimic workday, simulated workday, I'm not convinced you can necessarily do a 3 hour real workday, because that's going to be harder than a 3 hour simulated one. So I actually try and get people to build up to a 4 hour simulated workday from home. And if they can do that, I feel confident that they can do a real 3 hour workday, because a real workday is going to have increased stressors, probably more demands, anxiety is going to rev up, right? All these things. So that's usually my initial plan for starting someone off. And in terms of, at what point do you say, let's send you back to work, or let's start this plan to go back? Usually it's once they're a lot closer to that even initial 3 hour mark. Then we say, okay, things are looking optimistic. You can do 3 hours. Let's get you to 4 in the meantime, and we'll start the process of, choosing a return to work date and getting all that set up.
I mean, now in the era of COVID and work from home and Zoom and email and everything else, and a lot of people are able to be remote. Do you ever start them early with return to work and just like reduced hours, because you're cutting out commute, so I've done this with patients, more recently, where it's like, okay, let's start with just 2 hours but at home based work, and you can kind of
Exactly.
stretch it, do you ever do that?
Absolutely. And even pre COVID, I mean, a lot of my recommendations were starting people from home because they had more control over the lighting and their environment and the sound. So that COVID has definitely made that easier for most. Although there are some patients who working from home has been worse for them because they have little kids running around and
Mm,
it's noisy. And so it's very patient dependent. I would say the majority of patients I work with working from home has been helpful in that sense. Now there is the isolation aspect of it, which has been further challenging in other ways. But from a work tolerance perspective, yes, working from home is helpful. And yes, I have patients who we've started even with a 1 hour workday like that. It's more rare. I find it tends to be around what insurance wants to do. So insurance tends to have minimum hours that they like to have people go back at, and depending on the patient. I mean, if they're working from home and insurance and their employer is okay with it, yeah, we can send them back for 1 hour. But it's a lot harder to go from 1 hour of work to 2 hours of work than it is to go from 3 to 4 or even 2 to 3. And if you think about, a percentage of, if you do 1 hour, you're doubling that, right? Versus if you do a 2 hour workday and add one more hour, well, then that's just a third, right?
yeah.
That you're adding on. So, or you're, I guess, adding on half of that more.
Right.
My fractions are a little confused, but you get the gist of what I'm saying,
Yeah.
right? So
Yeah.
the percentage gets smaller of the additional effort. So part of why I tend to push for the 2 or 3 hour minimum rather than one is because I have more confidence in their success,
Yeah.
and because the last thing I want is for a patient, to go back to work and then have to come off work again.
Right. Yeah, I've never thought of it that way in terms of the overall, because I think, going from 1 to 2 is not a big deal, but when you put it that way, it is. It's you're
It's a big
doubling it. Yeah,
difference.
you're doubling it.
Yeah, and I say that to my patients for all their activities too. Like when they're trying to read again or do screen time, if they're at 1 or 2 minutes and that's brutal, to add on one more minute is still going to be really, really hard. But once they have 10 minutes under their belt, well, to
Mhm.
go from 10 to 11 minutes, that's only 10% more. That's no big deal. So
Right.
um, I think that plays a big role. And then the other thing is once they've started their return to work, insurance is like pushing, 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 pushing. Like they only want them to spend, 1 to 2 weeks at each stage before they go to the next. So again, I'd rather send them back in with like the most support and the most likely success. And so that's just sort of where I've seen that situation. But I've definitely done 1 or 2 hours. It's more case by case.
Yeah. And I mean, just speaking about that insurance, thing, and I think that's where I think that's where the insurance industry kind of shoots themselves in the foot by trying to rush this, especially if somebody's been
Hmm.
out for a while, right? Like somebody who's just injured. I mean, yeah, I'm just as likely to push them back fairly quickly too. But somebody's been out for a while, when you start putting that kind of pressure on them to, speed the process up, they're only going to hit a wall and end up
Yeah.
set back and end up starting from scratch again. Like
Hmm.
it's not,
Well, it's
it
nerve
doesn't serve,
wracking, right?
the
Yeah.
purpose. It's just,
Absolutely. And like it's funny how, people don't recognize this more, but we know the impact that stress and anxiety has on our performance and on our health. And so you'd think, these people should be making you feel as good and comfortable as possible. And thus you'll be more successful in your return to work. So I think this is something that people don't recognize as much as they should.
well, think about it from like a productivity standpoint. You can't think straight. You can't be productive when you're coming at it from a place of anxiety and stress. Like
Hmm.
that's you're in an overwhelmed state. And if you think about it from like an autonomic nervous system, dysautonomia, sympathetic dominance, and all of a sudden you throw the stressor in of like, oh shit, next week I have to go up to this much, like that right there all of a sudden just hits like, I don't think I'll be able to do this, and then that adds that overwhelming anxiety feeling. Whereas if you go, okay, I have time, and I've built the
Yeah.
confidence to know that I can do it, and
Hmm.
now that I have the confidence, going up that one extra spot is not going to be a big deal
Hmm.
for me. Um, and I think that's where the insurance industry needs to understand that, because they actually shoot themselves in
Hmm.
the foot by, blowing the whole thing up.
Absolutely. And I think, something I do with that in mind too, to help my patients feel more at ease and to give us more wiggle room to modify the plan ongoing. Because as you know, there's no timeline for concussion. I mean, we have our clinical judgment and sense of, oh, this person's here. It might take them this long to get to here, but there's really no telling at the end of the day. And so something that I always include in my work letter for patients to their employer or to their insurance is just um, a little note at the bottom of our plan saying, note this plan is subject to change according to the patient's symptoms and activity tolerance, and will be modified ongoing with occupational therapy support. And it just sort of gives us this out. And what I've had is, let's say a patient is at 4 hours a day 3 days a week right now in their plan, and they're like, what, I'm really struggling, like and I think, they're close, like I don't want to send them back, I don't want to take them a step back, but I don't want to progress them either, because that's not going to be good. We send a little letter off, we say we're going to keep them here for 2 more weeks and then reassess. We give them 2 more weeks, their body and brain have adjusted by then, they feel better, bam, we're good, we go to the next stage.
And are they pretty accommodating with that?
Usually, because they don't have a choice. And so it's really funny because, insurance companies typically want a week by week guideline, week of November 1st, this is how many days and hours and when you're working. And then the week of November 8th, the same thing, and so on and so forth. And so when a company requests that, well, of course, yes, like we'll do our best to spell it out for them and say, no, this is subject to change. But my favorite scenario, and where I usually start, is I actually don't offer up a week by week plan. First of all, I used to even say week 1, week 2. Now I actually just say phase 1, phase 2, because we don't know how many weeks we're going to be at each phase for, right? So when they request week by week by week, I do it in phases. If they insist on weeks, then I say, between 2 to 4 weeks at each stage. So this might change. So what my go-to model is for this is actually not to lay out a week by week or phase by phase plan, but just say they're going to return to work at this number of days and this number of hours. Let's say it's 3 days a week, 3 hours a day. And then from there, continue to progress with ongoing occupational therapy support. And that way there's no pressure on the patient. We see how they're doing. They want to get back to work. They want to progress. I mean, it's in their best interest. They're not getting paid their full salary by their insurance. So, even just financially speaking, most people are going to want to get back to work. And then we just see week to week, and we have our own plan together with what we're aiming for. But that way, it doesn't, what ends up happening is we have to go back to the insurance and we have to say, here's the updated plan. And then this week gets pushed here and this week gets pushed here. And so I just find if the insurance accepts that, I start with that. Sometimes they accept it. I'd say 30% of the time they accept it. 70% they come back, they say, can you lay it out week by week? And so then we do that.
Right. Do you ever deal with, and I don't even think it's mostly insurance, I deal with employers that do not want to provide any type of graduated return. It's either all or none, right? And I'm thinking of a particular case, where an individual was promoted to a higher, stress kind of role with a lot of moving parts right before they got their concussion injury. And my recommendation was to go in and shadow that particular role and kind of gradually work into that so that you kind of get the lay of the land, because he had never really done the job, and then now he's off for 6 months, and the employer was saying basically, if you can't do the job, you can't come in. How do you deal with that? Like, aside from setting up, and I mean, this was like production line stuff where they're monitoring moving production lines, having to like there's a lot going on there, I'm sure. And you would have difficulty even recreating that in a home environment. So, what would you do in that type of scenario?
Yeah, it's a tricky scenario. I mean, I think, it is pretty rare when an employer says, no, you can't do modified hours. I think more often I see that you can't do modified duties, or we can't accommodate, like, in a perfect world, I would have my patients go back to work and not have any set fixed short-term deadlines. I would have them not learning any new responsibilities, but doing more familiar tasks to start, transitioning into progressively more challenging things. So in a case like this, where I guess in this example, were they saying, you can't even come in for like a half day per se, you have to come in full-time hours? Was that what yeah,
that's like
so upsetting for these patients. And I don't know, it's tricky because they have the duty to accommodate, um, but technically, they could argue, well, and up until the point where it's not feasible, right? So they could say, well, given the structure of our workplace, it's not feasible, and you could get a lawyer and take them to court, but really, who wants to deal with that when they already are struggling to function day to day with a concussion? And um, so it's a whole complicated mess. What I've done, which has been helpful in the past, is I've had meetings with myself, the patient, and their employer. So usually my communication is back and forth with the patient, and they're telling me, my employer said this, my employer did this. When you as a healthcare provider get on a call with the employer and see each other face to face as humans with the patient, it's a lot harder to say no. And you as a healthcare provider are saying, this person's not going to get better unless they do X, Y, and Z. And it's not going to help their recovery. It's going to make them more sick. I find people tend to get a little more creative. And because you, as a healthcare provider and an expert in concussion, understand, what's beneficial, and then the employer is an expert in the work duties and roles available, you can put your heads together and come up with, okay, what's actually reasonable for the workplace, and then what do I see is reasonable for my patient.
That's good. That's good. The other thing I was thinking is I should get an employment lawyer on this show to talk about what the rights are of.
That would be incredible.
Because I don't think that I don't understand it, obviously, and I don't know if you have any insight as to what the employer is actually required to do. Do you have it? Do you know? Like, are they required? You said something along that line. I was just going to try and press you on it a little bit, but like,
yeah, I'm going to pull up the exact wording, but I think it's basically like duty to accommodate till undue hardship is basically what it is. But it's like define undue hardship. Like it's a bit of a general
legal, right? Legal.
Exactly.
There's a show on Netflix right now called Made, and
yes, I was just I knew what you were referring to.
Yeah, and she's in court and she's trying to battle, but she's representing herself. And they did such a clever thing on the show where the lawyer stands up and talks to the judge and just goes legal, and it's just supposed to show you how like we as lay citizens would just not understand what the hell is going on. So anyway,
exactly.
that's why I said that. So
undue hardship.
So maybe having a legal on might be the way to.
That would be awesome, and explain examples. And it's hard because what is undue hardship? I mean, like even having someone on disability, yeah, like that probably is hard on your company because you're paying someone to be off and you're paying someone to do their job, and you're shorter staffed, and right. So it is hard. But to what point, is that accommodation? Should it be honored or not? And it gets really tricky. But I definitely have patients who have had to work with employment lawyers, and I'm seeing some people in the comments saying employment lawyer on the show would be amazing. So I look forward to hearing that episode.
I am going to put that on the list.
Amazing.
I think that would be good. Just because it's like, a lot of times it's like you don't want to go through the hassle of trying to find somebody just to get this advice, but knowing your rights, I think would be super empowering. And so if you could put that out there in a domain that allows people just to see it, on YouTube or on a podcast or something, and just understand that they have, certain rights, and the employer certain obligations might allow them to, advocate for themselves from a place of a little bit more strength. So I think that's a good idea. Yeah. Now, obviously, if you're doing a physical job, this is how I do it, and you can tell me if I'm right or wrong, but I usually make sure that they can pass a treadmill test before I allow them to go back to a physical job. Is that kind of how you roll too, or?
So we do a similar. We do a bike test with our physios. So treadmill test modified on the bike. Yeah. I usually what I do is I defer to the physio. So that would be more or chiro, and that would be more within their scope of practice, working on the physical aspect of things. I help with exercise training and building things up. But in terms of making that call, are they physically fit to return? I usually defer to the physio or chiro for that.
And then cognitively fit. So, obviously modifying, duties as much as you can, and progressing things as much as you can. And I know that you do a lot of, cognitive-based rehab strategies. What is your, because I have I go back and forth on this a little bit, and I'll kind of explain that after. But what's your kind of process for determining, like, when to impose cognitive based rehab and what type of rehab to include? Is it purely based
Mhm.
on symptom report from the patient, like I'm feeling like I can't remember things? Like, how do you go about that?
Great, great question. So I would say, because most of the patients I work with are concussion, mild traumatic brain injury, the large majority usually have pretty strong, good insight into their challenges and strengths.
Mm.
So I would find it very unusual if one of my patients had significant cognitive issues, but weren't aware of those. And perhaps they don't know maybe to the extent necessarily, but I would say large majority of my patients have pretty good insight. So usually I start with patient report. And depending on what the job is, I would consider potential, and depending on what their symptoms are, I would consider doing a more in depth cognitive assessment. So our clinic has a cognitive assessment that we do through another party, I guess not clinic, but organization. And we do a series of cognitive tests through them. And that helps to just create more of an objective display of what's going on. Now, what I found is that most of what we find in these reports is consistent with what the patient reports, which is great because it means it's doing a good job and it seems to be pretty accurate. It's not definitive one way or the other. It's one additional piece of the puzzle that you can refer to and have some more um, objective information from. But usually what I do is a combination of patient report and or a formal cognitive assessment. And then based on the challenges identified, we go through some rehab strategies for those. And then we either redo that cognitive assessment and or see what the patient report is like on their challenges, and go from there. And the thing that's really nice actually about going back to work with cognitive challenges is a lot of the strategies and accommodations that are used for these cognitive issues tend to be very appropriate in a work setting. So, for example, where my patients struggle is they can't remember key points from a work meeting. Well, they can write it down and take notes. And so where they actually struggle is socially because they're not going to be talking to a friend with a pen and paper in their hand, taking notes as their friend is talking to them, having a normal conversation. So we have other things that we do for that, but from a work setting it's actually very conducive to various accommodations.
So I'll give you my I don't even want to call it a hesitation, but my thought on it. And I've talked to neuropsychs about this as well, is that a lot of patients that perceive cognitive problems actually test within the range of normal on many neuropsychological evaluations, right? So because some of this stuff is very subjective, that and I don't know how much of this is included, but it's been heavily studied that, like things like nocebo effects and things where if you perceive that because you've had a concussion, you're going to have memory impairments, attention difficulties, it seems to manifest.
Right.
And
Even
so
headaches, even everything. The classic example is, my patient tells me they went out to IKEA and they came home and had to lie down for 3 hours. And I'm like, when I go to IKEA, I have to lie down for 3 hours. Like it's hectic there, right?
yeah.
So there's a
Yeah.
lot of that.
Yeah, so like I've spoken to neuropsychs about this, and they say that most people that report memory problems don't actually have memory problems. Most people that report
Hmm.
that they have issues with attention and whatever don't actually,
Right.
they don't present with cognitive, true cognitive impairment. So
Hmm.
my my first strategy has always been around kind of education. And I think a lot of times if you think about something like, let's say, in a social construct where you're speaking with somebody and you believe or perceive that you have an inability to remember parts of the conversation. Well, if you're having a conversation with somebody and your mind is thinking like, I'm not going to remember this, you're not focusing on the actual conversation because you're distracted by
Exactly.
your own thought process. So
Exactly.
so then I start to I kind of go to the realm of like, okay, does this person actually have a true cognitive impairment, or does this person have issues with inattention? Does this person have anxiety? Does this person have
Yeah.
other things that may be distracting them from the
Hmm.
cognitive tasks that they're
Hmm.
trying to perform? I mean, I know you guys have psychotherapists, and I'm sure that gets heavily included, but how much do you think about that?
So I think about it quite often, and I think what's really nice and makes things a bit easier, actually, from my perspective, is that as OTs, we're not so concerned with diagnosis, we're more concerned with function.
Right.
So if someone comes and tells me they're in this conversation at work and they can't remember anything, we're going to practice strategies to write down keywords, to maintain their focus, to take regular breaks. And whether it's their anxiety or an actual functional issue, it's not as relevant because the strategies are the same.
Right.
So, I mean, yes, perhaps, if they're having lots of anxiety, we need some more stress and rest and relaxation strategies in there as well. And referral to psychotherapy. I mean, that's always like some people, it's more required than others, but you're going through a traumatic thing in your life. Like you need support. Like
Mm-hmm.
that's a lot to take on. So, always psychotherapy, all, and, it's just, I think it comes down to function and seeing what the person's issues are. The other thing I was going to say is that what's nice with the testing we do is you get basically a range that, are you in the normal range, below average, or above average, compared to a normal, healthy person who doesn't have a concussion. And so, what I see with a lot of my patients is many are within average. Some have some categories that are below average, and then some have, a combination. Something's below, something's above. Now, what we don't know, and this sort of gets into, you and I talk about baseline testing a lot too, and we don't know what their pre-injury normals are, right? So some of
Mm-hmm.
these people might have really strong memory, but really poor planning and organization skills.
Mm-hmm.
And so we don't know what that would have been prior. So what I do when I get these results is I look at what their lowest scores are and whether that corresponds to where they're experiencing challenges. And those lower scores, for example, sometimes I work with patients on things that showed up in the average range for their test. And let's say all their scores were average, but that average is somewhere between like 87 points and 100 and whatever, 13 points. And maybe it was on the lower end, maybe they got like a 90. So it's not midpoint of average, it was on the lower end, and it's been problematic for them. And maybe pre injury, maybe they were on the high end of average, but we don't know, right? So
Yeah.
we always just bring it back to function. Are they feeling like this is a challenge? Is it impacting their ability to socialize? Is it impacting their ability to successfully do their job? And then the strategies are the same.
Yeah. I love how you said that, because what it does is it says, well, this injury or this issue may have been pre-existing, but you say that it's an issue for you. And whether it is due to stress and anxiety, either way, by doing the rehab and doing the repetition, you reinforce the skill and you learn that you can do it, which gives you the confidence to do it. And then maybe in the next social situation, you're not, getting distracted by the thought that you can't do it. You're feeling confident that you can, and all of a sudden it's working wonders for you. So I think that's good. And I think what you said too about having, the normal, we consider that, oh, we're looking for things that are below average. Well, you may have scores in the average, but this person used to be exceptional at certain things. Now, you can't always
Exactly.
rely on the patient report, because the amount of patients that tell me that I have the highest pain threshold you've ever seen. Every patient has a high pain tolerance
Amazing.
according to them, and this is bad. So you can't always rely on necessarily what they say, but that's the thing, we don't know. But if they are reporting that this is an issue, then I see that we should be working
Yeah.
on it. But I think that including the mental health aspects, and one thing that I say, like when I describe to patients what a concussion is and why PCS may be included, and I go through my list of my 5 kind of things, where I say, number 1 is autonomic dysregulation, number 2 is kind of inflammation hormones, that type of more systemic things, gut health, number 3 visual vestibular, number 4 neck, number 5 psychological. Now I say, now this one is always involved to some degree, because you've been dealing with this for 6 months. How could you not have some
Mhm.
anxiety around it? How could you not feel depressed
Right.
about it? And those are barriers. So in order for you to get over those barriers, we have to address this, because it's always a part of the picture in persistent symptoms. And the longer it's been there, the more it's there. But oftentimes, if you don't explain it in that way, patients think mental health, you think I'm making this up, you think that and it's just not the case.
Right.
And so I think that the way you framed that was really good. Anything else on PCS before we kick into acute?
I think we can transition. Let's do it.
We can transition. All right. So getting people back to work after months and months of being off is obviously a lot harder because you're starting from, you know, a place of basically, nothing. They haven't done anything for months potentially in many cases, or they've been told to sit in a dark room and, not even walk outside or, look at a phone or anything. And now you're trying to get them back to a computer. You have a lot of barriers to overcome there. Now, let's say, like, how early do you think OT should be involved in the clinical process? Should this be something that every patient right away, boom, OT is part of the clinical picture right from square one? Is that how you see it?
If it was free or if people had the resources,
Perfect world.
100%.
Yeah.
Perfect world, 100% OTs right away, access to care within a week of their injury, get them started on a plan. They probably will never have to see you again.
Right.
Right.
Exactly. Yeah.
And maybe for a return to work plan to make sure they're not doing, things the wrong way or too much too soon. My patients who I see early, they almost never need to come back. Maybe one-off session. It's the patients who have, taken longer and then now are stuck more in this PCS cycle. So yes, in early intervention right away, if you can afford it, or if you have coverage for it or resources. And then from there, just, depending on what your needs are and how you're progressing.
Well, hopefully we can get that set up with CCMI in the course that you're going to be creating for us. And
yes, I'm so looking forward to that.
Yeah. So how early, let's go through your acute return to work strategy. Sure. Somebody's come in, it's been 3 days since their injury. Where do you, where are you at? Where do you start?
Oh my gosh, it is so individualized. Like I have patients who, day 3, they're like, you know what, I feel pretty much back to normal. But can they do their normal activities or not? So I'm going to try and slow my thinking down here because there's a whole bunch of different scenarios that I'm picturing. And so let's start with the patient who's feeling good. And then we'll talk about the patient who's not feeling good. So the patient who's feeling good, like they had their injury, maybe they had, some headaches and dizziness and nausea for, 1 to 2 days. And you see them on, let's say, day 3, and they're like, yeah, like I barely have a headache anymore. I feel pretty good. Well, just because they feel good, you're not just going to say, okay, you can go back to work. You need to look at, again, can they still do their daily activities? Can they get outside for, a 20-minute walk? Can they go on their computer for 20 minutes? All these basic things. If yes, then we look, okay, can you do more than that and sort of bring them up and see where they're at. So by the time they meet you, let's say they've been on their computer all day, it hasn't made their symptoms worse. Probably what we would say is, okay, keep doing what you're doing, keep building up your activities. Let's plan for a return to work for Monday, but we're going to just start with half days, 3 days a week. So even if they're feeling perfect, I still want them on a modified schedule because it's just better to go too slow than too fast. And if they have to take 1 extra week of work, that's half days more than they needed. That's so much better than being off work for an extra 6 weeks more than they needed.
Mm-hmm. No, I think that's great. Okay, what about the other one?
Yeah, so that's the patient who's feeling good. The patient who's not feeling good, we're not even going to touch their return to work until they can do some minimal amount of their daily activities. So can they do, these markers are sort of arbitrary, but can they even do, 10 to 20 minutes of basic things like going for a walk, like using a computer, reading, all these tasks that you need to do to a much greater extent in work? If the answer is no, we're not even considering work yet. We're just like, can you function a little bit in your day to day and getting you back there first? And then once they can function and do these things, we're building them up again to that sort of 3-hour block of time. And once they can do that 3-hour block of time, we're saying, okay, let's work with your employer, with your insurance, if you have, to figure out a return date, which will be sometime in the next few weeks. And then keep trying to build in the meantime up to that 4-hour day so that we can send you back for a successful 3 hours.
Nice. Okay.
So I'd say, I would just add one thing is I would say it's pretty similar to those who are in the more persistent symptoms category. The main difference is that when you're in the earlier stage, I work with patients who are like, really, I feel fine. Can't I just try a full week? And if I don't feel good, I'll go off. And I just say like, absolutely not. Like you will thank me. And they always do. They're like, you were right. That was so much more draining than I thought it would be. Like even just being off work and then going back is draining. So
Mm-hmm.
even without an injury. So yes, like always just go slow. What I tell them is, if you go back and do the half days, 3 days a week, and you're like, this feels super easy and I'm fine. Sure, the next week, go back, go full time. That's fine. That's your choice. But that very first week back, you've got to do it modified.
Mm-hmm. I mean, I try to, you know, find analogies for patients too. And even just being on a vacation for a week, when you come back, your first 3 days of work, you're like, oh my God, like, how do I do this normally? It's like you have to
Right.
build up your stamina again. And I think that it's, you know, it's more important. And plus, when you think about what's happening in concussion, you have this sympathetic drive, right? Your autonomic nervous system is all a whack, so you need to kind of work on pulling that back a little bit. So I think that's really good advice. I want to go through the chat here and see if we have any questions before we go, because we get limited on Instagram to an hour. So if anyone has any questions regarding, you know, return to work, your own thing, put them in the chat and we'll see if we can get to them here. Somebody's asking about vision therapy. Is it helpful 3 years plus? Yes, it can be if you have a visual issue. Let's see. Did you see anything? Employment lawyer. We're going to be talking about return to school in the new year, so I didn't want to bring that up, but we'll talk about that at the next time we chat. One of the most frustrating parts is getting my doctor to hear me. Yep. All right. Let's see if we have any coming in here. Lions Mane. That'll be a topic for a Dr. Herkel one, I think.
Exactly. I was thinking the same.
Yeah. Yeah. All right. It doesn't seem like we have any questions. Great. So do you have any final words? I'll plug your Instagram and your socials again. At Jenni Diamond Health, JENNI Diamond Health, and at concussion OTS, or it's concussion.ot. Sorry. Oh, here we go. Somebody says, why does my mind go blank when I'm asked questions about my injury? I mean, I think that's pretty broad. It could be a number of different things.
I was thinking the same. Yeah.
Yeah, it's hard to kind of.
I would get to the root of that. I would do some reflection.
Mm-hmm. Yeah. Currently working as a teaching assistant 2 days a week and wanting to move. And because a healthcare assistant, is there anything I should do? I'm not sure I understand that. Can you see that question there, Jenni?
I can see it. I don't understand it either. If you can just send it again and maybe reword it.
Currently working as a teaching assistant 2 days a week, wanting to move. Do you mean move locations or move jobs? And because
maybe
of healthcare.
And become a healthcare assistant.
Yeah, we'll see if she gets back.
Okay.
And then somebody's asking, will this be available later? Yes, it will. It'll be on YouTube. At the Complete Concussions YouTube. It'll also be on my podcast, Ask Concussion Doc. What about somebody who is highly educated and experienced and was out of work during the time of the accident, and now I've been out for over 2 years? How do I ensure success with the search? This is a great question. Somebody who's not working, how do you get a job? Because nobody's going to take somebody who's, you know.
It's really tough. You might have some advice as well. I was just going to jump in and say, one of the best things that I think you can do is take a role initially that is lower down than what you are actually even capable of, knowing that. And maybe that's even volunteering to start, right? So maybe it's something unpaid just to, get used to being on your feet and or doing stuff on your computer. Maybe it's something, a step down just to give you back that confidence, and almost think of that role as your rehab. So you want to think of that as, you're not getting back to your ultimate high paying job yet, but you're going to get back to something that's, a step along the way just to rehab to get there.
That is the best advice. I
Thank
love
you.
that. I love that. Like, cause it's, people go, well, I was this and I want to get back to here. And it's like, yeah, but you might not be able to do all that at once, right? Like I used to run marathons and now I haven't run in 6 years and I want to try and run a marathon. Well, you don't start at the marathon. right? You start really, really low and you kind of work your way back up the totem pole. And it's frustrating and it's maybe a bit ego damaging,
Yeah.
but I think that's such a great way to look at it is, gain the confidence, gain the, the day to day. Okay, here we go. Yes, become. So this person wants to become a health. I'm trying to piece it all together here.
A healthcare assistant.
Wanting to become a healthcare assistant. So you're wanting to switch jobs, I think, essentially is what we're talking about. Still 2 days a week, but just a new job. So I think it might be the same thing. I don't know. You're going into a new role.
Looking at what demands there are involved in that role. Are you capable right now of tolerating them from a symptom perspective? And then aside from, the symptom tolerance standpoint, it's a new job. It's a new learning curve for anyone. And so breaking things up, going in as prepared as you can be, maybe working also with an OT to help you. And, if there's opportunities to start part-time, even that could be helpful as well. So.
Somebody's asking if the school one can be done earlier, but because they want to be able to listen to it for Christmas break. That would have been smart of me to book it that way, but I didn't. So it's going to be January 19th, unfortunately, because we have other ones booked kind of in the interim. So apologies on that, but yes, that's a great suggestion.
Send us a message if you have questions on the Concussion OT's Instagram. And
you can use that resource too. Okay. I think that was great. I think that was a great discussion. And if people have questions, feel free to message Jenni or myself either on social media or comment on YouTube or anything else. Any final parting words? You can check out the Neurology Centre as well if you're looking for a referral, if you're in the Toronto area or even from elsewhere. I get a lot of requests from people in the States and Europe and stuff. So maybe somebody wants to venture.
Yeah. And I guess the only last thoughts I would provide around returning to work and the role of an OT, because we spoke about that gradual return, but we didn't get a chance to speak too much about types of accommodations. And just know that there's lots of different accommodations that an OT can help you get in your workplace, whether that's taking regular rest breaks, whether that's being able to use earplugs or taking a break in a quiet room if you're in person. There's so many different things that your healthcare provider, not even necessarily your OT, your chiro or your physio might be able to help you with that. So, or your family doctor. So just make sure to ask for accommodations as you need them and work with a healthcare provider to put those things in place.
Right on. Jenni Diamond, thanks for coming on. Thanks guys for joining us on the live here on Instagram. I'm going to shut it down now.